Hello, everyone. Welcome to Blumber Healthcare Podcast. Today we have with us Dr. Deepthi Shanbhag. Here we are. She is one of the team members of the Department of Community Health at St. John's Hospital. She's a wonderful personality, my neighbor, my friend, and it's so nice to know her. Welcome on board, Dr. Deepthi Shanbhag, and I'm so happy to host you today.
Thank you so much, Pushpa. It's my pleasure and honor to be here with you. And it's a good thing that we are neighbors.
Yes.
Thank you
yes.
so much for making me a part of this podcast.
Great. Today we will be exploring about your journey, about what made you take up MBBS, community health, and the disability services that you have been contributing to, and the data collection, and everything that you have been part of.
Sure.
So, before we start off, can you please tell us why you chose MBBS as a subject and what inspired you to become a doctor?
That's a good story because the inspiration behind this was actually my father. So when I was fourth standard, I'm the youngest in the family, and when I was in fourth standard, my father, who was 50 that time, had a massive heart attack.
Okay.
So we were in Bangalore, he was in Mangalore.
Oh.
So he was admitted to one of the good hospitals, which is Father Muller's in Mangalore.
Okay.
So when I went to visit him, he was under such nice nursing care and doctor's care. Somehow that young mind of mine actually took that, the environment and how they have actually saved my father.
Okay.
Because if I saw his ECG much later after I finished my MBBS. He actually had a very massive heart attack.
Okay.
It's great that he survived that, because that was a time when we didn't have angioplasty. I don't think there was anything else apart from ecosprin, bed rest, and oxygen. That's all. So with this, those doctors have saved him, and nursing care was so very good, so clean environment. So I think that was really, and the white coat and the faces and all. I think probably that was there in my mind, and I told my father that I'll grow up to be a doctor and I will give you injections. So maybe that was actually the starting point. And yes, my parents, my family supported me in that.
Okay.
So that is how my journey is, and I studied in KMC Mangalore. I got through government entrance, I got a seat, and KMC Mangalore is again one of the best medical colleges. And that was a time when Father Muller's didn't have a medical college. Now they have.
Okay.
But I had very good teachers, excellent professors, good skills which was imparted to me, and really till date I don't think I ever regret that I have taken up medicine. So as far as community health goes, it's a very rare subject, but was not my first choice actually. It was either pediatrics or medicine.
Okay.
But somewhere along the line, I always wanted to work in a rural area. And I wanted to do some kind of social medicine kind of.
Okay.
So one of my friends actually said, why don't you try St. John's? Because St. John's that time in 2001 had its own entrance.
Okay.
So I took the entrance because she insisted that it will be good for you, it will be good for your attitude, So I got through the entrance and I joined in 2001 my MD in community health. So that is how that journey started.
Okay.
And my department actually showed me that community health, the sky is the limit. You can do anything what you want. And till date, it's been 25 years since I joined my MD in community health. I joined immediately as a faculty. And again, till date, I really love my subject.
Okay.
And I have really no regrets of joining community health. That means I somehow I think destiny had it in me that I have to do MD in community health or not MD in pediatrics or medicine, which initially I thought was my choice. So I think that is one destiny I think I believe in.
Awesome. So that's something to take off.
Yes.
Yeah. So when you joined community health at St. John's, let's say in your early years, was there anything that felt that you are going to make an impact because you are taking up something very important?
Not really. I think when I joined as a PG, postgraduate, I had only thing I had is study.
Yeah.
So I really didn't know what I should do after I get my MD.
Okay.
But my professor actually asked me to join back as faculty. And he said, you look after disability.
Okay.
So that is his Dr. Dominic, who's my professor. So he said, why don't you look after disability? And there was a project which was running, a program on disability which was running. So he told me, please look after, let's see how it goes. So that is how I started working. So as a postgraduate and as a faculty, it's two different roles. As a PG, you are only into studies and nothing else.
Right.
But as a faculty, your horizon opens up and you can think of so many things. So with that baseline of disability, I started going one step after another. And when opportunity came knocking, I always make sure that I took the opportunity, whether it is attending a conference, doing a training, whatever it is. I've done everything possible in disability. And with that, I've gained experience.
So what was that first project on disability?
So we did what is called as a community-based rehabilitation. So it is actually, what we did was we have a set of health workers in our rural area. So my area is rural area, Mugalur.
Yeah.
So we actually did
Mugaluru near Electronics City.
Not Electronic City. This is Sarjapur Road.
Sarjapur.
So Sarjapur Road ends in Sarjapur. From there, it's around 5 kilometers.
Okay.
So in Mugalur, the first thing which we did was needs assessment. So you have a load of persons with disability. What are their needs? So that is what we did as a survey, and we collected data. So that is where the data comes into picture. So when we collected data, it was both adults with disability as well as children with disability. There were around 500 odd persons with disability who just came into our purview, and we actually did what is called as a situation analysis. What is that they require? So we went by the WHO guidelines of health, social empowerment, etc. And we did this. We found that 80 or almost 90% of them require some or the other form of intervention. It may be health, it may be something to do with their education, it may be something to do with their livelihood or empowerment, or even social interpersonal issue. So for every person with disability, we made an intervention plan. We had a team of multidisciplinary team looking at their health. We had social workers who looked at their counseling. We actually networked with the government so that they take up these children with disability into the school. So like an inclusive education. We try to do a lot of livelihood. I mean, these are all continuing. Even now we do the same. So livelihood also, we got people to come and train the persons with disability in paper play, bag making, those are the things which we did. Empowerment, we have self-help groups of persons with disability. We have currently now around 25 groups and more than 350 persons with disability, maybe nearing 400. We have around 500 children with disability who are enrolled in our rural center. So things are just going, one after another like this. Yeah.
So 25 groups, and to build these 25 groups, I mean, you would have spent your 25 years into it.
Yeah, and of course, it's always teamwork, Pushpa. So it's not just me. I have a big committed team with me. And that is the first thing which community health taught me, that it is always teamwork. There is no hierarchy in our department. Every work which we do adds up to reaching the ultimate goal. So we have a set of health workers, 13 of them, and each of them were given the task of starting a disabled group in their village.
So and these are the community health workers.
Yeah. Exactly. So they were trained in disability, they were trained in needs assessment or that survey format, and they were also asked to do one disabled group, self-help group in their village. And that is how it has added to so much. From 1 it became 2, from 2 it became 3. So like that, initially it was only 3. Now over time it has expanded so much that now we have 3 federations. That means these 3 groups have actually formed a trust. They have registered trust.
Each of the groups,
they have not 3 of them out of 25, 3 of them, they are federations. That means in their group they have representatives from different self-help groups, and they have registered as a trust. So like that, we have 3 trusts which are formed. They are so independent that now there's a time when we used to invite them for World Disability Day. Now they invite us and say, please come, madam. And they'll feel very bad if I say, no, I'm not able to come. But they do it very nicely. And we are quite happy that they have attained that level of sustainability and empowerment, that we are really proud of it. Yeah.
So these 2 decades, 2.5 decades that you have contributed, what kept you going? What was the motivation? What made you grow or build so many groups, so many people, helping so many individuals?
I have no idea. It's just, I told you, it's just that opportunity comes. And see, over time, we also have funders. And those funders actually started training us in newer concepts of disability. And they also wanted us to put this in practice in our field practice area. So that was one of the motivations. Then when I went out and interacted with a lot of people, either in the conferences or some evaluations where I went, so it was a rich experience which I got. And I asked myself, if they can do, we can also do to a certain extent here. So that was the motivation for me to go on. And yes, the committed team. So I tell anything, my health workers, my staff will take it, with really positively, and they're very enthusiastic to do more. They will never tell that, madam, this is too much, we can't do this. So more you give, the more happy they are. So recently we had a training for caregivers and grassroots level workers in 3 different districts. I didn't go for it. Health workers, I have a coordinator, she went, and my postgraduate went. And they were so happy to go. They did the training very well, and they came back and they said, we are willing to do more. So since you have such a committed team, obviously you feel very happy. And yes, my department has supported me. My management, that is St. John's, whether it's the dean or director, has always supported me. So that is the thing of keeping me going. I will go on as long as it is. So
you have a trained set of doctors within St. John's who are helping you also, along with the community health workers whom you have trained. And they have expanded.
Correct. They're all ladies. So they're all strong, empowered ladies. So that also is one of the things that it keeps on going and it doesn't end. So that is how it is, Pushpa.
So over these period of 2.5 decades, how has your role evolved? Like you started off as a professor,
as a teacher, as a doctor.
As a doctor at St. John's. Now you're training people, planning and organizing things. So how is your
So over years, as you know, that with responsibility, with strength comes the responsibility, the Spider-Man's thing. So I think with increasing number of years, with greater responsibilities, you have to up your role. I mean, you cannot be a small team there. So now I'm the team leader. There was a time when I was a part of the team and my professor was the team leader. Now I have put myself in his shoes, and you have to up yourself to that. And because you have experience of so many years, naturally you kind of fit into the role. You don't require to have any training. And so many years I've been in St. John's and in the rural center. So automatically your mind starts thinking in a different way. And so I was just a doctor. I used to do only these things, just do this, just do that. But now I can think, okay, let's do this, let's do that, So the last 10 years, I've been more planning and telling my team to what to do. So I think it naturally comes because you are in the same place for so many years, right? So naturally that hierarchy and that higher level of thinking probably comes with experience, Pushpa. So that is how it has happened.
You're a natural leader then.
I don't know about that, but people listen to me. So, and when they do that, you feel you are motivated to do more, because you have an excellent team. And that is what I've learned in St. John's. It's an excellent team, teamwork everywhere, no hierarchy, there is no hierarchy.
Yes, maybe I'm wrong, because you're hands-on. You have always been hands-on. You have always been a listener and empathetic. I think all of these trained you also to be a leader naturally, and that's why people are listening to you.
So yeah, I think the way the empathetic part started coming from my MBBS days. You do role modeling. There's a teacher, he'll take class for you. So you listen, that's theoretical. But when he goes to the hospital, how he behaves with the patient, how he interacts with the patient, what sensitivity he shows on the patient rubs on you. And you're young, at that time. You're 18 to 21, your mind is molding and you're passionate, you're really intent to become. See, I was somebody who I really wanted to become a doctor. So when I started seeing my teachers doing all this, naturally those qualities, your brain started taking like a sponge, and I think it has the empathetic behavior probably started from then. So it's not something which is learned, it is something which is just built, and over time it has had it. St. John's, actually KMC and St. John's for me have been my two best things which has happened in my life. KMC gave that foundation, St. John's built on it. Because again, I had a set of professors who are extremely good, who are very professional, very ethical, So it built it on what I already knew, but in the direction of community health. So yes, so I think God has been really kind to me in that way, that I had two excellent medical colleges where I learned, and yes, I think I've made best use of that.
Your foundation has been very strong.
Yeah, I think foundation and 2-3 floors have been very strong.
That's why we see 20-year tall buildings.
Yeah, it can be tall, it can be horizontal also, whichever. Yeah, so that is what it is.
Yes. So you are a community healthcare professional. So beyond the patient itself, you have been taking care of the environment or educating the family members and educating how to help the patient being taken care of. Can you elaborate a little on that?
Yeah. So in community health, we believe what is called as the social determinants of health, which is basically you have a person, but the person gets the disease because of several factors which surround him. So it's like a semicircles. It may be his or own constitutional factors. It may be his family. It may be his society. It may be the overall policy of the country. Everything affects that person. So we try to delve on why is this person like this? Why did he get the disease? And if he has got the disease, what's the next thing? How can we prevent a follow-up? So community health was also called as preventive and social medicine. Even now in North India, it is called preventive and social medicine. So here in Karnataka, it has become community medicine. But then it's still preventive and social medicine. So how do we prevent that person from getting the disease or complications, or his family members? So there may be some diseases which may be genetic. For example, diabetes, hypertension. If the parents have, the children, there's a high chance to get. So you start screening them. That means when you get this patient with BP and sugar, we will ask them, who is there in your family? And if they're all adults above the age of 25 or 30, we'll say, have they got their blood pressure and sugars tested? If no, then we will insist, please bring them, we want to test. Then they say, aren't they too young? I said, doesn't matter, why don't you bring them? So that is one part, which is what we say as secondary level of prevention. There is something called as primary level of prevention, which is you still have not got the disease, but you still have risk factors. Like you may be smoking, you may be obese, you may be sedentary, etc. But you still have not got the disease. So we also suggest physical activity, nutrition, then so many other which are health promotion measures, which actually can prevent. So he may have risk factors, but we are preventing the disease from happening. So that is primary level of prevention. So we try to do that for all family members, especially the children. So for us, primary level starts with children. And then secondary level, which is early diagnosis and treatment. So you have adult, diagnose, treat. Then tertiary level of prevention, especially for disability. So the area which I work goes into tertiary level of prevention, where we already have persons with disability and you try to do rehabilitation, try to give them livelihood, try to do the best for that person to be productive. So those are the 3 levels of prevention. Of course, there is one called primordial level, but let me not go into that. So, but then our mind thinks in levels of prevention. And there is one also levels of recommendations. So if you go to a physician, it will be individual recommendation. Pushpa, you are sick, take this treatment. But for us, it's not like that. You are sick, so this is individual recommendations. Then you have family recommendations. Who are in your family? Also, you have a mother, you have 2 daughters. Okay, that you look. So what is that we recommend to the family? So that's also a part of our recommendation. Then we have a community also. So we look at the community as a whole and see what's the best possible we can give even for the community level. So like the surveys, health educations at the, at a major levels, in the schools, for example, all that are a part of our life. So it is not just doctor patient, but it is much beyond that.
I remember once when we were having our initial conversations,
Yeah.
you mentioned that once there was chikungunya, that
Yeah.
pandemic
Yeah.
that was
Yeah.
spreading, and
Yeah.
Wes actually went to the places
Absolutely.
to identify.
Absolutely.
Yeah.
So you're right. So I was just, I think, fresh as faculty. I just finished PG or 1 or 2 years into faculty.
Yeah.
You are right. There was a village which had chikungunya, and chikungunya that time was really new for us. So we had to read what chikungunya is. Same mosquito as as dengue, which is Aedes. So we went to the village. We actually did house tours because most of the cases came from 1-2 villages. So we actually went house to house and started looking at where the mosquitoes are breeding. So we actually did what is called as outbreak investigation. So we went and we saw they had tanks inside the house where larvae were growing. So it was not just a survey. We actually went into the house, and when we saw that, it was actually like I was telling you, it's like Sherlock Holmes. So there is a murder. Yeah. Dr. Grace, Dr. House, okay. But yeah, that is how we did. And we found that who's the culprit here? Just like the murderer. Here we found the culprit was those tanks which actually were growing mosquitoes. And we said, please clean the tanks, dry it, So those are things which are followed even now. And it's one of the most important points for controlling either dengue or chikungunya, because the vector is the same, which is the Aedes mosquito.
So cleanliness has to be.
So like that, we have done plenty of other investigations. I remember once I'd gone to one factory actually. So my professor sent me, that time I was a postgraduate student. There was an outbreak of diarrhea. So he said, please go and find out what's the problem. So I went and I actually interviewed every person who had diarrhea. I went to the place where, they were cooking, everything I saw. And then we came to the conclusion, who was the culprit? So like that, we do quite a few investigations.
Apart from preventive, you
investigations, absolutely. So right now, of course, we that time we were all junior staff. Now we have juniors, so they do it, but it's quite interesting because the way they, we do have some outbreaks which happen in the hostels and all. So it's a whole load of things which we do within that all happens in a day, Pushpa. It's not that it should be very quick, because within 2 days we have to find who's behind all this and what do we do to control it immediately, otherwise it will spread.
Very true, because it's like you're dealing with humans.
And see, the density of our population is so high, so it can spread, and in hostels and it's very fast. So that is why we have to give good measures, immediate measures, so that they can take it. And scientific, it should be with scientific, it should be evidence based. Just chuma, we can't tell many things. So that's also a part of our work.
So right now, the treatment, like you said, right? I'm a patient and you're a doctor. I come to you and you give me treatment based on what? Is that the correct way? Like everybody is doing that right now. But is that the correct way, or do you think there is a prevention method or the investigation method that needs to be incorporated into everyday practice?
I think, see, I do agree that doctors are busy. They don't have much time for the patients. But there should be other suggestions and advice to the patient, whether it is counseling on nutrition, counseling on physical activity. Everything has to go together as a package. So it need not be the doctor, it can be, let's say, a counselor, a social worker who's actually doing all this. That's possible, or a nurse who's trained in all this can do. But it has to be a complete package, it has to be comprehensive, because just treatment may not be enough, especially for lifestyle diseases like diabetes and hypertension. The medicines will have an effect only if the other non-pharmacological methods like physical activity, diet and all has to be followed. So it has to go hand in hand. What happens is they'll take medicines, their blood pressure won't come. This thing is, you raise the tablets, but you don't have time to ask, did you follow the dietary advice? are you have you reduced your salt? Those are things which you don't have time to ask. Yeah, exactly. Those questions never come. So your mind automatically, what's the next drug? Those are things. There are a lot of issues. It's patient overload, and you have to finish your OPD. They can't go on sitting for a long time. So those are issues, no doubt about it. But if it is a holistic thing, that's the idea, actually. Yeah. And we try to do that in a rural area, in a rural health center.
With all the community health workers.
Yeah, so
please tell us a little about Mugluru and what you did there.
Yeah. So Mugalur, our rural health center, started way back in 1993. It was started by our super seniors, and they said St. John should have a rural center. And Muglur is a very far off village, very distant village. It was almost, there was no transport to the village. So it was a very cut off village, actually. So that is why they thought, okay, let's have it in Muglur. No, 93 there was only probably a mud road from Sarjapur to Muglur. That is so there's hardly any traffic, and rather there was no transport. There's hardly any health systems and health services. So they said, okay, since it's the last village, so a PHC, usually the border villages are the ones which has lesser, because they are in no man's land. Neither it belongs to the other center, we say primary health center, nor it belongs to this primary health center. So they are just like border districts. These are border villages. So this was in the border of two. He will wait here. I know. That's the same in my house also. So what, you'll edit this, that this part you'll cut.
That's why I had to stop you, because so much of information you're providing.
I know, it's okay. No problem. No problem at all. No, should I look at you or should I look at?
Sometimes you look at me.
And sometimes to that, okay. Yeah. Because I think I'm looking there. So
it's absolutely fine, actually.
Is it?
Yeah.
Okay.
That's really good.
Okay. Look there. No. Anyway, yeah. Shall I continue? Yeah. So we were talking of Mugalur, and that was the reason, because it was a cut-off remote village. They all said, okay, let's have. And at that 1993 was also the silver jubilee of St. John. So there was one State Bank of India fund which came, and they said, okay, let's put it into the health center. So this is what my seniors have told me, and that is how that center started. So it started with a small OPD, which was run by interns, and then over time it grew, because every year a new project came. And the beauty of these projects was, it was not just project. Project means it has a limited time duration. That is why we call it as project. But here, most of the projects continued as a service. So the department took it on itself, even if the fund stopped. Let's continue with the service, because it is giving a lot of service and it is benefiting the rural area, the people. So that is how each year many things started. So we had a women's project, Mahila Vikas project, then we had hearing impairment project, then we had Drishti, which is eye, then disability, then senior citizens clinic, mental health. So like that, every year many services started. Now we have all the days except Saturdays, something or the other which is going on in our rural health center. Okay.
5 diagnostic centers. What it is still operating on a daily basis?
5
diagnostic centers, like
actually the services, not centers. The center is the same, but we have on Mondays, for example. See, it's a 24/7 health center. We have doctors there who are postgraduates, we have interns, and it is run 24/7. When I was also a PG in St. John's, I stayed there for 6 months. Yeah, that is where I gained my administrative skills, because that's where you actually learn how to manage people, how to manage money, how to manage material, how should you organize, how should you plan. That 6 months was really, and you don't have time. See, I did in 2001. That time you didn't have mobile at all. I mean, I used to go far off and hello, how are you? That kind of a thing. So we had one landline. For any emergencies, we had to call, say, department, say, please send a vehicle. So even ambulance was not there. And I remember we used to do deliveries. I remember a lady, me and my colleague, one more girl was there. Both of us were PGs. We actually, there was a bullock cart, and this lady had delivered in the bullock cart, and we actually came running because we had gone for a walk. We saw the bullock cart. We came along with the bullock cart, and you can imagine that is how it was there. And yeah, we have had deliveries which used to come with almost the head out, and so those were the times. That this was 2001, 2, 3. This was when I was doing my PG. There was hardly any toilets. Some of them were home deliveries, so that is how. And over time all these services also added. So I had the fortune of seeing many of the services start either during my PG time or as a faculty, and now if you see, that area is unrecognizable because there are no home deliveries. People are go in a four-wheeler, and they don't have to come to a rural center. They straight go to St. John's or any other hospital. There are so many of them, so they can go there. There are, every house has first and second floor. All the houses have toilets, so all that, so it has almost become peri-urban, it's, you can't say it as a village. So what had a mud road has actually, and we used to see ragi fields, when you go there. Now we hardly see ragi fields, so it has urbanized so much. And yes, people also have improved, their quality of life has improved, their socio-economic status has improved, mainly because I think education, literacy, accessibility to Bangalore. Not many of them, farmers' children will not take up farming, they will come to the city. So those are the things, and people will sell their lands for whatever reasons. So it has become different, and that 25 years of me, I've seen that, it's quite a bit to see, but I've seen, if I remember then and now, it's two different worlds. But there are few things which are still the same. You still have people who are lower socioeconomic status. You still have people who are disabled. You still have elderly who require care. Still, mental illness has gone up. Non-communicable disease have gone up. We hardly used to see diabetes, hypertension. Now we see from the rural area, 25-year-old, 30-year-old having diabetes, hypertension. So we feel they're all strong, they all work hard. Not really, it's a dual burden. So one side you have infections, the other side you also have non-communicable disease. So our center is primed to both, we are seeing both now. So that is how it has grown. And with changing times, our mindset also has changed. So we think more of diabetes, hypertension, rather than something else, which used to be diarrhea, cough, cold. That also is there, but yes, so that is how this rural center has come. Yeah, like I said, over here, so there's a saying in our department which says, no survey without service. So if you're doing a survey, please follow it with a service. Otherwise, survey will become just, a cliche, it's very pure research. It seems very selfish, just to take data, like making use of the people but not giving them back. So this is what even medical students, we have trained them. They do a survey, but they also give health education. So we have actually trained them that you are collecting data, you're taking value add from them, you're taking their time. What is that you're giving back to them? So we are giving back health education to them. Now we have FAP where we have health camps also, but this is a way of giving back to the community, and we tell the students, they're also learning. Remember I told you about role modeling?
Yeah.
So now the students are seeing us and how we behave, how we are, etc. So that is what it is, Pushpa.
So how did you initially or over the years engage with those communities in Mumbai? Because you have built them, developed them, trained them. So how did you engage with them initially to build trust?
These are stories which I've listened. I mean, by the time I came in 2001, the community had total support for us. So when it started in 90, these are all things which I've learned from my professors. It was very difficult. It was very, very difficult. A lot of resistance. So some of the social workers, one of them actually stayed in the village, and that is how they build rapport. They went to the villages, talked to groups of people, women especially. So it all started, the entry to that village probably started with women's groups, because they are the ones who are very receptive to information, and So that is how it started. Yeah, we have.
Emotionally
Exactly. Yeah. And there is something called as we have what is called as a health committee. So from the day of inception of Muglur Center, this health committee was formed, which are representatives from different villages, and every month there is a meeting of the health committee till date, where these people come and whatever issues they have in the village, whatever issues they have about the doctors, the center, they will bring it up, and that is how we have maintained the rapport.
Kind of understanding the
Yeah,
feedback
yeah,
and
yeah.
how you could improve.
Exactly. Yeah, and most important, our 13 health workers are from those villages. So they have a good connect with the community, and they are actually representing the community. There have been times when they have given a feedback, and many things like an outbreak, for example, they are the ones who actually inform us. So that is one. The government health system is also there. So we work with collaboration with the government health center. So we come under Sarjapur Primary Health Center, and every primary health center have their own set of health workers, be it Ashas, ANMs, Anganwadi workers also are there. So we work collectively with them as a team. For example, immunization for children, we get it from the primary health center. It's free. So we don't get it from St. John's. They only bring it, vaccinate the children. It's free of cost. So that is how we have actually tried to do in collaboration with the PHC. So there is no duplication of work. So overall, it has been a good mix of all this, kind of public-private, I won't say partnership, but definitely collaboration and network.
Like you have been building your set of community health workers, and they have been training them. And you said the initial 13 workers have built it across like 25 groups, and they themselves have converted into 3 trust foundations. How did this model come up? Like, why do you think this model would work, or how did you modulate all this?
I think it was the need of the hour. Because in community-based rehabilitation, see, we are more, St. John's is a medical model. Our strength is health, to give medical services. But then at some point, our medical services saturate. In the sense, we have done the best for that person. We have given him wheelchair, or we have done a surgery. So what, after this, what is he going to do? That is the thought which we had in our minds. After this, what? So that is how it went into different aspects, like education. For example, a child education is very important. So we make sure that the child is sent to the government schools. We don't have special schools there. So we talk to the school teachers. We have a good connection with them, and we try to send the child to the schools. The next is adults with disability. What do we do? We have done the best, and they are probably at some level. So can they all come together? Because self-help group is an advocacy for rights of persons with disability. It's one of the steps of rights. So we have in the country, there's an act called as Rights of Persons with Disability Act, which came up in 2016. So according to that, there's a whole load of rights. There are some 13 or 14 chapters, and they have a right to everything, including education, including empowerment, etc. So how do we actually approach them? It's better to go, if they want to fight for their rights, instead of one person fighting, it should be a collective action, right? So if they want to fight for their rights to self-help through a panchayat, for example, let them go as a group. Those are the things which kind of pushed. And yes, I was also trained in CBR, and a lot of workshops I've attended, lot of CMEs. So many things I tried. Okay, these are things which are happening. Why are we not having this? We are just restricting ourselves to medical model. Let's go beyond a little more. So I won't say, see, in a medical college, we are not a really NGO. See, in an NGO, they work only for persons with disability. Here we have so many other things to do. So, but then can we do this? Because that's a very important step towards advocacy for persons with disability. So we tried, and we found it successful. And now health workers have taken, so they're doing it on their own. And some of them want to start more. They actually say, shall we start here, shall we start? So they have only come, and they have been motivated to start more.
And the services that you said, right, the 5-6 services that you started with help of these health workers also. do they get a choice to choose, or you will be the deciding factor?
So it's not just me. Actually, each of these projects are headed by a faculty. Senior Citizens has one faculty who's heading, Mental Health has one faculty who's, I'm in charge of eye care, ear care, non-communicable disease has one.
Gynecology also.
MCH, you're right, maternal child health and gynecology as a faculty. So it is divided among us faculty in the department. And each these 13 set of health workers, there's actually their salary comes from different projects. It's from different sources actually, but we have actually worked it out with the funders, telling that you may fund, like let's say my project which is disability related. I have told our funders that they will be doing other work also. They will be more of multi-purpose workers. That means when they go to a village, they will not just see persons with disability, they will also see somebody with diabetes and hypertension, which is little beyond their purview. That's the same with all the so over time they have become multi-purpose workers because of the training and the experience which they have gained with us. So most of these women have been with us on an average 15 to 20 years. Yeah, some two of them of course are a little recent, but most of them, 2 or 3 are recent, but most of them are in an average 15 to 20 years. And they are quite motivated. They are a part of women's group. We have women's group also. We have what is called as GHK, which is Grama Hiriyara Kendra, which are all elderly. They're daycare for elderly. So like that there are a whole plenty of things which are happening. And all health workers are a part of all the work which happens. So, and we don't restrict. Each of us project in charges, we will never restrict them. We want them to be a part because they're a very important human resource for the center. Like I always say, they are the eyes of the center. We may be the heart and the brain, but they are the eyes. They are the people who work in the community. They are the ones who get the patients for us. So and they don't hesitate to go a mile further, to do work. So that is the model which we have. It is a women's empowerment model. All are women. So and the criteria for selecting these women also has been fantastic. So our staff, our social worker staff, senior staff have selected such that they're all daughter-in-laws of the village. They have been active in a lot of community work, maybe women's group or any other health education awareness programs, and their communication skills are good. So with that, their selection process has been so good. We have not had attrition. We have had 1 or 2 mainly because they got married, but they were excellent workers. Other than that, I think those which we started are still there.
Strong team.
Very strong team. And they, the beauty of that is they go on a 2-wheeler to all these villages, muddy roads, their back will go for a toss, but they will never say no. They will never say no. So that is the the spirit of these women. So I think our base is that group of community health workers, and we don't treat them differently. We all kind of they're same to all of us. And I won't say oh you have to. If I have to scold, I scold all of them. Like that it is. So unbiased. Same with other staff also. If they scold, they'll scold all of like children. No, we won't see whose children. They all have been naughty. All of you get scolding. So like that. So but then they have been really good. I think that is the motivating factor for us, for me at least, to continue working. And this is a model which we show our students. When they come as interns, they see these ladies working. And we make them interact. They're so good that they do audiometry, they give hearing aids, they assist in cataract surgeries. The students are floored. And they also do, go give health education. They drive a 2-wheeler with the student going. Fantastic. So that's a good role model for students. These women are really in that way, quite professional. Even though they are 12th standard max, but fantastic group.
Awesome.
Yeah.
Now, what criteria, what makes you take a decision that this is the project that you are going to take up next? Like to execute in Magaluru, what is the criteria that you identify?
It's a collective department. So I think the most important criteria is, does it add value to the services which we give? Does it add quality to the services which we give? If the answer is yes, and is it sustainable? Will it stay? Even if the funds withdraw, will it stay for another 10 years? If the answer is yes, we take it up. But most of the services which we do, or most of the projects which we do, are community based only. We don't take up pure research projects. There are people from other department who do come and collect data, but our department doesn't do that. We actually are very rooted to the community, and even if there are surveys, it has to be community based, and in a way we give something back. Like many of our students, postgraduate students, their thesis are in the same villages where we work, and the theses are selected in such a way that they add quality to the already existing services. So one of my postgraduates did on caregiver burden of children with disability. So we knew what the caregiver burden was, and he did an intervention also. He trained our health workers to do an intervention on those caregivers. The burden actually came down. So it's adding value, right? So like that, many of those theses. Right now, we have one of my postgraduate has done on costing of children with disability. What is the cost of taking care of a child with disability on everything, whether it's medications, therapy, etc. So we are still in the process of getting the results, analyzing, and that is again adding quality to the work which I am doing. So that is also one of the things which we do. Like that, all the postgraduates do work or thesis in something which is already existing to add value to that service. So that is what I think is the project which we take up. And these projects don't give us anything. It's all projects, even if it is 2 lakhs or 3 lakhs, it is going to the community only. There is nothing which is coming to any of the faculty. We do not expect it. Not the hospital. So it goes straight, and the hospital does not have any issues. You get 1 crore for doing orthopedic surgeries, they are fine with it. They'll be more than happy. They won't say give 1/2 to us. No. So that's the best thing of St. John's, where your mindset is altruistic. You feel that this is for the general good of the community. And I think that is what keeps us ticking. The more you get and more you say, I'm getting equipments for this, I'm only getting, they'll be very happy. There is no questions raised on it.
What kind of transformations you have seen in these 13 women workers that you have?
Okay.
What kind of transformations have you seen over the last 2 years?
So I think from being very okay, you do this, I will do this, that kind of a thing, which is more of given task and I am going to do, that kind of a thing, to more empowered, taking initiative, being bold, to talk to, informal or formal leaders, standing for your rights, standing for what you feel is not okay, talking to women, talking to parents, and saying this is not how it has to be done. Those are things. Also telling me, ma'am, you can't tell this. Those are things they, so that is the transfer. So they have become more empowered, much more empowered. And I think they have gained respect in their community because now they are health. Yeah, I think initially when I heard, this is all again my seniors telling me, very hesitant to take up these jobs. They hardly used to come out of the house. Now they have also gained dignity and respect in their own families, in their own community. See, this is a lady. So they also ask, shared, problems with them, etc. Many times I've seen patient comes to me, tells quite a few things, then goes. And then health worker comes back, said, you know what, she also has this. She should have told me. No, ma'am, she told me. So that is the thing. So exactly. So you feel happy about it. You don't feel bad. You'll feel very happy. Okay, my health worker has more connect to this woman because she's there all the time. I go there once a month, twice a month. So that connect, when you see, you feel very happy about it. So that is how it is. These women have really grown up, and many of their children are married, so they have been so empowered that despite all their family issues, I've seen health workers go through, lot of family issues, very serious issues. But you see their children growing, getting married, they becoming grandmothers and all. It's really nice to see them. So I think in that way they have really grown as a person, as a team, and finally contributing to our health center. Yeah, yeah. And of course, I can go with the good feeling that even if Deepthi goes off, if I yes, yes, the health workers will do. If I go, department is also not there. I'm 100% sure that these ladies will carry on working.
During our early conversations, you had once mentioned in the conversation that you don't allow anybody to take any service free of cost. How do you go about that?
Yeah, so that was a rule. I won't say a rule. That was a decision taken by, again, the ones who actually started the center. So they felt that you give value to a service only when you pay a small amount for that. So it probably that time it would have started maybe free. Yeah, a rupee or 5 rupees or something like that. It would have, till recently it was 10 rupees consultation, and then it became 50. Now it is raised to 50. For a specialty it is 100 rupees or even less, I think. That's all. It is more of a user fee, so that they give value. So nothing comes free in life, Pushpa. So this is what they have to understand. Even our medications, we have tried to reduce the cost. We get generic medications, and it is probably 1/4 of the actual cost outside. They have to buy that. I mean, we have got the concession for them. Most of the patients have no issues. I've seen patients taking out one 10 rupee note and giving, but we won't hesitate to take it, because that's the value they're giving the medicine.
Can be free of cost because
Yeah, yeah. Otherwise, they might just throw it off, the medication. So here they've actually given a value, and when they give a value, we are 100% sure that they'll go back and use those medications. So it's not a very, of course, we do concession, give a very nominal, and despite the socioeconomic status of the surrounding have gone up, but still we have kept the consultation fee to the same. Yeah, yeah.
Why is that?
Because see, one thing is, it's also a training.
The reason why I'm asking,
Yeah.
Earlier on, let's say their socioeconomic status was not great, and they had to perceive the value of what they give.
Yeah.
But now that perception is like
So now actually you're right, Pushpa, but many of them, if they're very rich, they may not come to our health sector. So there are private hospitals where they go and they pay a cost. Here, many of the people who come to us are still the lower. So it's not that all 100 of them have become rich. Maybe the 30-40 of them have become. The middle class and lower class are still, they still are deprived, so they still come. The second is the elderly. We have lot of elderly who come. So if you look at, he or she is from a rich family, but they are dependent on their children. Especially so when husband dies and only wife is there. And these are all stories which was told by the health workers. So one of the ladies came and she wanted concession for a cataract surgery. We do it for 5,000. Or maybe that time it was 2,500. And she asked, "She full gold and all?" And I know that family is quite rich. Then her husband passed away. Then the health worker told me, "Madam, do you see, this is where the health workers connect becomes important." She told me, "Madam, do you know that her son has actually thrown her out of the house? She is staying away. She doesn't have any money. So that is the reason we have to give her concession." Right? So even though you have people who may be coming from apparently rich families, they are still dependent. So we are still continuing to give the concession. Second, we are not really a profit-making organization. We are there for a service, and we have to give that service at a small cost. Okay, and all these are subsidies. That means that cost is already borne by something else, so or some other funds or some other projects. So this is just to give value to that service which we are providing. That's all. So that is why we have still kept it in the same thing.
For you, you said data is important. Right?
Yeah.
How important is data in community health service, and what kind of uses it has as a country as a whole. Like if you look at, we are taking fragments of data from
Yeah,
Mangaluru,
yeah,
and then that is still useful if we have to compare it to somewhere in Maharashtra or in Madhya
yeah,
Pradesh.
yeah.
How has that been evolving over the period?
Are you talking of Mughlu, the data which we
Data
collect from
collection,
Mughlu?
yeah.
Yeah, I think that is something. So we did what is called as a health management information system. You know, when we did this during COVID. Yeah, because there was a lockdown, but healthcare workers could actually go, and we always wanted to have the baseline data. So we actually developed a software. We have health informatics division, so St. John's Research Institute. So I told them, in fact, it was a need from my side. So we write this data in papers and paper, and this was, way back. This is before COVID, where we didn't have digital. So so much of paper, where will you get cupboards? We have to store 5 years data. That is legal, and there's no place.
For 5 years, you were not storing the data. Was not
No, not like that. See, at least 5 years data you require to store. After beyond 5 years, you don't have to. You can actually discard it. 5 years data is a huge data, especially if it is paper based. So we have OPD data, we have survey data, we have minutes, we have so many things. Can we digitalize it? This was my simple question. I went to our Dean Research Institute. He's the head of health informatics. He said, "Okay, Deepthi, let's work it out." And that is where this health information system started coming. So they actually developed. Then it was actually mostly for disability data, which I wanted, baseline. But the department decided that if you're doing house to house with all health workers, you might as well do all the data pertaining to those houses. So that is how the health management information system started. So these health workers, same ladies, were given a tab. Tab was not heard of that time, okay? So they were given a tab. So all of us bought tabs from our respective projects. All the 13 health workers had a tab. We developed a software for them where they could actually type it on to the tab. So they started going house to house. So they covered, yes, they covered around 30,000-40,000 with a mask because it was COVID. And so because lockdown was there, we made use of this opportunity and did this baseline. So of course it was a difficult task. It's a difficult task, but these ladies were very motivated to do it, and they did. They covered around 25,000 population, and every house data we have, and that kind of added. And we took even disability data, so much so that it is called e-Punarchetana. That platform for disability is called e-Punarchetana. Punarchetana is rehabilitation. So that is so good that it can actually spot out a person with disability if it is entered. So I have to just say, please, track all the persons with disability with locomotor disability, physical locomotor. So it will all give red dots all over. So it's like a spot map. Okay, track all with visual impairment. So I actually could do a spot map with that. So we had we had full data of those houses. Second, we also had good data on disability and where they are going, all that. So that was my baseline data. All the thesis, by the way, the PG thesis and all the information with the health workers, all based on this data. So if I ask how many elderly are there, that data, yes. So that is how the data becomes very, very important. It's actual data. Of course, it's a different thing that the data has been added. The population also has gone up. A lot of migrants have come now. It is not just the permanent residents. A lot of migrants which has happened. So there have been ups and downs of the data, but that baseline, even today, helps.
Do they still continue collecting data?
They do collect. They do collect and start adding it. So we've moved out of paper based. We are still, yes, we are still, we do tab based data only. So the health workers, by the way, were so smart that they picked it up so fast, and the health informatics team were amazed with it. Yeah, they picked it up like that. So, and we also, in our OPD, that is eye care and ear care, we use what is called as BAMNI. So that is a OPD based data. That also is paperless. So it is entered, the patient's detail is entered immediately. You have 3 or 4 laptops in different rooms. The data gets transferred all over the place, and it collects into a server. Yeah, so it is all paperless. Previously, all rooms used to have books,
Right.
and that book, if I start, it will take another 1 month to enter the data and get me the analysis. Now it is just on a finger. So that is also
So
done.
previous data, which is paper based, it was also digitized.
Yeah, that was anyway digitized because it went into Excel sheets.
Right.
But that used to be one person doing it, and that had all issues. You know, she's not there. It's very difficult to enter so much of data. So we wanted actual data, immediate real-time data. So that started coming from COVID onwards. So till date it continues.
Now, this data has been utilized by, as you said,
Yeah.
PC
Yeah.
students and the PG
Yeah.
students, and
Yeah.
also in formulating certain kind of medicines or
Yeah, even planning of a service, how many women in the reproductive age are there, those are things which you can, we have a data entry. She knows how to analyze data. She will give, it may be 5% more than what we did that time, but it's obvious that okay, at least baseline we know that this is how much it is. So
during the earlier conversations, apart from you being participating in so many activities, you're also a positive contributor to disability as a whole. Can you please talk a little about that?
Disability as a whole means in the.
You said you were working with Netherlands.
Oh yeah, Lily. Yeah. Over time, yeah, we have actually. I have been a part of several evaluations, and I have also participated in a lot of conferences, CMEs. I've traveled all over the world actually. So the recent one which I've done, I'm doing actually is a consultancy service for a Netherlands-based organization called Liliana Fonts. So Liliana Fonts is actually working with children and youth with disability in 2 continents, Africa and Asia. So they want to build what is called as a community-based rehab center of excellence, which is more on a virtual level, but it is a center of excellence for everything, research, training and all, and they want all the Asian countries to be a part of it. So that is their actually the goal. So what goes into this center of excellence is what I think they put out a call for, and one of my senior colleagues, she's not from St. John's, so she asked me, can we apply for this? I said okay. Like I said, opportunity comes knocking, don't miss. So I said okay. I knew it's a big task, but then I just said yeah, fine, let's do it. So then we applied for it. They had an interview, and a few days later we got a mail that you are selected. So that was in January, and we have been talking to a lot of people who work with disability, experts in disability and in rehabilitation, and a lot of things which we have learned, because we are supposed to get information like a consultative process, put it all together, because we are asking them, what do you think is a center of excellence? What should be there, what should not be there, how should you sustain it, all that. So all that information we are collecting, putting it together, and we have a workshop in April in Bangkok, and we are going to put this across to them, and there is a group of 25-30 people who are coming, who are actually experts in disability from various countries, and we are going to put it together, make it a kind of validation kind of process, and we will have the Paka report of this is the CBR Center of Excellence, this is the way how you should move, so by June we are supposed to do that. So this is what I'm doing with actually thanks to her, because she actually initiated it. She's an independent consultant. For me, I have too many things, but again, I'm doing this because of the pure happiness, pleasure which I'm getting. Despite all this, I talk to people. Actually, the interview is more with her, and talking with the information which I get, you learn so much. You feel okay, they are doing so much, and so many things are happening in the world. For us, it's more of frog in the well, for me at least. So now I'm exposed to the outside world and what they are doing, and like I said, I'm very happy. And yes, I have taken permission from my management, which I'm supposed to, because it's an external organization. So they have agreed to that. So
the disability work that you have been doing across so many years, and the kind of contribution you're planning to do for the Netherlands Foundation, which is planning to set up a Center of Excellence in Asia. What kind of changes do you think for disability personalities themselves have to be made in India? Because I mean, India is also has a quite a lot
Yeah,
of
yeah,
population,
yeah,
and how can we help them?
yeah.
What
So,
changes do you think?
this center of excellence is a good potential
Mm-hmm.
for us to get data, you know. So the standardized data across
Yes.
disability sector is very fragmented. So I
Yes.
collect data in one way. You go to the another NGO, they collect in a different way. So if I have to compare their data and mine, it doesn't really match. So we require to have. So I'm really looking at, of course. See, I'm a consultant. I should have an unbiased thing when I look at the CBR Center of Excellence. But one of the potential areas is definitely data, to have standardized data, to definitely have multi-centric research in disability. With these countries together, you can actually do a lot of research on disability, which is again a very gray area. Not many researches are happening, especially in India.
Yes.
A lot of work is happening, but it is not getting translated into a publication. But this is an opportunity for India to actually do that. And the other thing, of course, is trainings. We can have good accredited training programs from very grassroots level to the very high level trainings for different level, including there are suggestions of even having leadership courses, etc. So these are things which India has to look forward to in the CBR Center of Excellence. So I'm just hoping that, India is a big country and there are thousands of NGOs. Who will be a part of that CBR Center of Excellence is a very difficult question. But if it unites all of them, it is really good. That's the other thing. It's all fragmented. Maybe it can bring all these sectors together to work, unified, in a single voice. So that is the thing.
I would look forward to this. Definitely. Now, for the young doctors who want to do something for the community,
Yeah.
what kind of suggestions can you give?
I think a doctor should be passionate, about his profession, about the patient he's taking care of, and be sensitive and empathetic towards that person. See, we shouldn't think that person as patient. He's a human being, and the pain which he goes through, whatever, it's not the physical pain, there is a mental pain. He comes from a very different family background, lot of issues in so all that they should actually look into, not just the disease. In the WHO, the definition is physical, mental, and social well-being. So if we are looking at only physical well-being, maybe psychiatrists are looking only at mental well-being, whatever. But then I think it has to be holistic, and a doctor, whatever be his profession, he may be a super specialist, he may be a just MBBS doctor, is complete only when they look at physical, mental, and social well-being of the person. And that is something which a young doctor should do. Of course, many of them may be commercial, whatever, for whatever reasons. But I think the passion towards that medicine, the intention to learn more, is something which a young doctor should, because nowadays every year new things are being introduced. There was a time the textbook used to be only one edition for 10 years. Now we have every year one edition. That means things are changing very fast. So you have to keep up with the time, know everything which is in the current context, as well as try to do the best for the patient, and try be humane. I think be grounded, be humane. I think that itself is enough. Because see, tomorrow I am also a patient. It's not that doctors can't be patient. We also will be treated by a doctor, and we expect this in a doctor. So I think the young doctor should actually ask, if my mother or father or myself is lying on this bed, what will I expect a doctor to do? If you ask that, that is where you actually are empathetic, when you put yourself in their shoes. That's all matters. Push for the rest is all experience. I don't feel there's a good, bad doctor, nothing. They're all good. It's just the communication skills, the way they smile. A smile also makes a difference in a patient. You should be very straightforward. Many times you don't tell the patient, what the diagnosis is. The patient party, they'll be very aggressive. You have to calm them down. It's your responsibility. You also should be, even though they are patient, the patients should be on doctors, not patients. So that is something which I think the younger generation should do and take it forward, because medicine is still considered a noble profession. And in Sanskrit, there's a saying, Vaidyo Narayano Hari. That means the patient looks to the doctor as a god, and it is still so in the rural areas. Nothing has changed. And there's a benchmark which we have to keep up. Hopefully, I'm sure it will happen.
Actually, recently I was reading one article. There, a doctor was had written this article mentioning that a couple of his friends who had treated a patient and the patient passed out in the while being treated. It was not in their hands. But then the families attacked the doctors and the doctors who were treating the patients became patients.
Yeah.
It's happened in a couple of scenarios.
No, it has happened multiple times in multiple scenarios. Especially during COVID, it was really bad. And there have been times when patients or patients' caregivers have, rather the caregivers have physically assaulted the doctors. So now there is a law which says that it's a non-bailable offense. So
the caregivers.
So if a caregiver assaults a doctor, that person can be jailed, and it's a non-bailable offense. So that's the law now, and it is put across all the hospitals. It was very difficult because in ICU care, patients are critical, and there may be chance that the patient passes away, but it may not be really the doctor's fault. It's just that the person was critical, but that doesn't, even if there is a certain extent of whatever error or something, doesn't mean you physically assault a doctor. That doesn't give a caregiver a right. There are other things in the law where you can actually put a case on the doctor. If you feel that there is a medical error, you should not resort to physical this thing. There have been instances where even girls have been raped and all. So that is going to a very deep. That is very bad. So I think that shouldn't happen. That's a very wrong way of looking at doctors. Doctors also human beings, right? And if there is a medical error involved, then there is always a system in the law where you can put a case. That's always there. But physical assault will not solve any issue. Yeah.
Very true.
So that is the thing.
Okay. So you said the mindset of the patients or the new young doctors should be that they need to learn, they need to grow, they need to understand the patient's mental well-being also while treating their physical issues that they have.
Yeah.
Now, if you had to change one thing in the healthcare system, what would that be?
I have no idea. The healthcare system. That's a very big shot. Yeah. I think I feel that see, the thing is, we are going to super specialty. For everything, for a finger, you have a finger specialist. I mean, thankfully, it has not gone there. But for every small thing, you have super specialty who are entering the picture. I think to a certain extent, it's fine. For complicated issues, I do agree. But most of us, what do we have? We have fever, cough, cold, diabetes, hypertension. Even a very basic primary physician should be able to do. So I think that thing of very high-tech medicine should be restricted. I won't say restricted. We should have enough primary healthcare physicians, yes, where people can just go to, for just cough and cold. Now what's happening? Cough and cold, go to chest medicine. But chest medicine are supposed to treat very high level lung diseases. So they will sit in their OPD and see cough and cold, which even a MBBS student could have actually treated. So they're also overburdened. So you're actually your primary health care. I think the concentration should be on primary health system, which is the first referral for a patient. So have primary health. We already have primary health centers. Have good doctors there. Many of the primary health centers don't have doctors. So it's for various variety of reasons. But we require primary healthcare doctors who are good in their skills, who can give the first contact medicines. That is what a patient requires. You don't really require a super specialist to treat fever and cough, which I think so somebody, people who are let's say cardiologist is trained to treat MI. Those are the things he's supposed to do. He will sit and see small chest pain, which is not really MI. Why? Because he's actually wasting his very quality time which he could have spent with somebody with actual MI. So I feel if I have to change something, just concentrate on the primary healthcare system. Tertiary level is excellent in our country. There are a lot of excellent hospitals for cancer or for cardiology, or they're really good. Make it more affordable, accessible, but also strengthen the primary and probably secondary. Secondary is where you have a pediatrician, you're a medicine, that kind of a little specialist. So strengthen these two. That's enough.
I know I've been taking a lot of your time, but I have one last question out of curiosity I'm asking. There has been two kinds of things that I have been missing. One is AI is going to take my job away, and second is by the end of 2030 there will be a lot of demand for doctors especially from India. Which of these is true, and what do you think is the future?
I have no idea. See, nobody predicted COVID, right? So COVID changed the way we look at life, the way we look at medicine, the way everything became digital. Even your payment now is digital. Before COVID, there was hardly, I used to use my card and cash, So COVID actually changed everything. Now nobody has cash in their, not even a credit card or, debit card we have. We just use our mobiles and go everywhere. So that is how COVID changed. But it changed, certain things were good, many things were bad also, loss of lives and all that. But it changed the way health system is looking. AI, I'm really not sure, because AI will strengthen. Nobody should say that it is replacing a human being. Nobody can replace human brain, right? So AI is only a software. You know that well, right? So it is only data, all the data which is pulled together, and it will give an algorithm. Suppose you have data only from America, because India you don't have that kind of data. You will get algorithms which are mainly for American citizens. So when you look at, so you enter all this, let's say I have a patient with these symptoms, I enter it. It will give a diagnosis which is probably for an American. I'm just giving a hypothetical situation. It requires a human brain to say, this can't be true. This is India. This is not the one. He's coming with cough, 3 weeks duration, and it is giving some Legionnaire's disease, which is American kind of. And here, no, that's not possible. This will be only tuberculosis. That is what is there in India. So AI replacing human being for treating patient is a very far-fetched thing. There may be places where it is definitely going to solidify, or what do we say, validate labs, all those things which can actually kind of give better diagnosis. By better diagnosis, reports, more gold standards kind of. So that is possible, but auscultating, no patient will want some machine to do. So we still have that kind of thing, and certain things like surgeries and all, you can never have an AI do it. So AI will only substantiate what you already thought of. And yes, AI requires, you cannot take it blindly. You have to think twice before you take the AI findings and put it into practice. So that requires human brain. You will have to say which is correct, which is not correct. So that is, so you have to take it with a pinch of salt. How it changes the healthcare system, I'm not sure. I think it will make it better, faster, that is all there, so that is there. But drastic change, I don't think it will be possible. Not for India. We have 1.4 billion. For it to drastically change, it will take 30-40 years maybe, because not everybody is connected to AI digitally like that. And government has to have AI as a policy. It is actually, it is going to happen, and we have a AI course now. Yeah, there is a course which we have to take as medical students or professionals. It's a free AI course which we can take. So that is something which is. What was the other thing you said?
I said by 2030, the number of doctors being required from India is going to surpass, like it is going to go 2x from what the current requirement is.
You mean the doctor population ratio? Are we talking of population and the doctors required for it?
No. Yeah, exactly. The number of doctors wanted from India and Philippines or surrounding countries, whichever are exporting doctors, is going to grow exponentially.
Oh, acha, you mean doctors going from India to out, like a brain drain?
Not exactly brain drain. It's like the requirement will grow.
In the country itself?
No, outside.
Outside?
Even in India maybe, but outside no.
I'm not sure of that. I really don't know. In India it will definitely, it is going up because our population is increasing. Our doctor population ratio is not that great, So we will have a high demand for doctors, But the problem is the doctors are concentrated in urban areas.
True.
60% are rural.
Yes.
So there the doctor population is poor. Right. Whereas urban is very high. You have every road has one private hospital. But in a rural, for kilometers you don't. And there are certain parts of the country where you will not find at all. So for them, basic health, they have to travel 30-40 kilometers. So that is where I said the primary health care is very, very important. Very, very important. So that is the thing. So I don't know. I mean, I have no comments on that.
So, doctor, anything that you think you want to communicate to the general people as a closing statement?
Take care of your health. It's very important. I think lifestyle, especially the lifestyle diseases, are starting at a very, very young age. So I think we have to keep ourselves healthy, both physically, mentally, as well as socially. I think having a group of friends, talking to them really makes a difference. And even in the family, I think family health is important. I think, that's the only thing. Keep yourself fit and fine. Be happy.
Awesome. Thank you so much, doctor. And
thanks, Pushpa.
It was really great having you on board. And I really congratulate you on all the achievements that you have made. We are MedBlumber Technologies. Blumber is a platform where we want to, we are building a networking facility for the doctors, for the healthcare professionals to come on board and talk to other healthcare professionals like yourself for job, for mentorship, just to talk everything. Blumber is being built for the doctors, for the healthcare professionals.
Thank you so much.
Thank you so much for taking time and working with me for this podcast.
Thank you very much, Pushpa. I hope it was useful. Thank you very much.
Very useful.